David, for putting these on with us.
Well, thank you for the nice introduction, Steve. It's for those that were here in November with Peter. Stephen was actually out of town, so I missed you. I appreciate you being here, and he shows back up with a beard. And who's this guy? But he lives in Utah. The weather's a little cold. For those that don't know where I am, usually I'm in Mexico. I'm actually in San Diego right now, and where I live, and it's 75 degrees today. So I'm in a t-shirt and no beard. But I told Steve I would have to be like 100 years out to even grow like in here. But you rock it well. I think you rock it well.
Thanks, David.
Anyway, I don't want to hold Peter up because, we got 2 hours with Peter tonight and he brought 6 hours worth of stuff minimum. And so I don't want to even take like 2 or 3 minutes, but Peter and I have been friends for a long time, and he's one of the finest ceramists and finest educators I've ever met. I mean, just an incredible human being. Nice thing about Peter is when he talks to clinicians, he sounds like a clinician. I mean, he has that much experience in the communication aspect with his clinicians, and he works with some of the finest clinicians in the world, in my opinion. It's just such a pleasure to hear a ceramist say, talk like you're one of us, and realize that, yeah, we live in a crazy world as well. So Peter, you're the only one I've invited back for a second time. And I hope you feel special with that. And, I was giving him a hard time before we started that my actually January and my November canceled on me. So he was the only one left. It was like, I was going through my black book and it's like, Peter, I wonder if he's available. But I would have him back a million times. Peter, you're such an inspiration to all of us. And we always have so much fun together. And this COVID thing has kept us apart, but hopefully we'll see each other soon. But without further delay, you're a ceramist. You have a lab in Staten Island, and you travel all over the world talking about materials, communication. I would think that was his key point. But welcome back, and I appreciate it. Happy New Year, and welcome to. We have almost 300 people tonight, and welcome to everyone that's here. We have some international people too. Someone said, "Hey, I'm from Egypt," so we got some from Egypt. We got 2 from Hawaii. One from Georgia. That's the only other one I saw. Welcome and knock us dead, man. Hey, this is before I hand it over to you. This is live. So if you have any questions, I'm going to be monitoring it. Use the chats, not the Q&A. Use the chats, and if it's a question that's apropos at the time, I will interrupt. Peter, if I wait a little bit longer than you would like for me to do, it's because he's on a roll and I don't want to interrupt him. We'll spend a little time at the end. And for those that can't stay till the end for whatever reason, or you have a friend or a team member that would like to watch this, it's available on the YouTube channel. In the future, you won't get CE credit for it, but you can watch it. You can share it with others. So knock us dead, Peter. I'm always impressed. Good to see you.
David, thank you so much. And an honor that I can't even begin to explain to you. Thank you for being for letting me be the person that you invited 2 times in a row, whether it was the cancellations or not. Either way, I'll take it. So thank you. You've been a friend and an inspiration to me for a long, long time. So thank you for everything, and I'm happy to be here. And yeah, please feel free, jump in, interrupt, anything you want. I think the one we did in November, I think for me was more fun in the sense that we got to really go through cases and talk about different things. Today, you challenged me more with the photography portion. You wanted me to really kind of dive into photography, what I'm doing and how I'm doing it. So for those of you who don't know me, as David said, I live here in New York. I'm actually in my lab right now, so I don't need to spend so much time showing you my lab or where I am. I'm also the editor-in-chief of Inside Dental Technology, which is an Aegis magazine, so you might know Compendium and Inside Dentistry. So I work behind the scenes there and write and help them, and great education for everybody. So it's actually nice to be here in my office. It's 8 o'clock my time, so everybody's gone home and we can just sit down and talk a little bit about photography and what makes this important. So let's start off with the basics. The word photography obviously has a pretty wide meaning, and I think part of the challenge when we talk about photography is the when, where, and whys of it. People tell me, well, I use it for this or I use it for that. And I'm going to tell you, for me, I think photography is probably the most underrated aspect of dentistry in the world. It's the thing that we need the most of and seem to have the least of. Now, I know we have a large audience here, and some of you are probably saying, well, I have a camera and I take pictures, and I'm still not getting what I need out of things. I think what we're going to try to go through today is exactly that. What do we need in the picture? Why are we taking all the pictures that we're taking? And what's the information that we can grab from these photographs? And I always say you can't treat what you don't see. And even though we see it live with the patient, having that documentation gives us information. It helps us to really understand how to treatment plan and diagnose through our cases. It helps us in the interdisciplinary process. We want to share that information with our teammates, our surgeons, your technicians, whoever you want to work through. Also for me, it's a monitoring process. I get to see where we started and where we finished, and I get to learn from that every time. And I can promise you that there's not a case that I'll show you tonight that I'm proud of. I feel like they could all be better. And the only reason I have that ability is I can look back on what I've done over the past 5, 10, 15 years and figure out how we can make that better. Also, not to be logistic, or should I say legalized, but from a legal point of view, this is documentation for you. I don't know how many of you have done large full mouth cases where a patient walks in with a mouthful of crap and you spend 6, 8 months making them look beautiful. And at the end, all they're asking you about is a little bit of staining on their second molar. And you're like, but do you remember where you started? So the process of really documenting your way through the case is really an important part for me. And I hate to be cheap and say the word marketing, but I think it's important. I've been into many laboratories around the world and clinical offices around the world. And I'm always surprised when I walk into an office and I don't see any beautiful before and after cases or pictures of teeth. And that's always surprising to me, because that's what we do. That's what we should be most proud of. So for me, photography starts here. It starts with the person. It starts with the human. And I always want to be able to look at that face. And I hope you all can look at this face. She's a sweetheart of a lady. She's been through a tragedy of a life and cancer and a million different issues that she's had, but she's a sweetheart of a lady. And I hope you look at that face and you look at her eyes and you could tell right away that she's not very comfortable. She's not happy with her smile. She doesn't feel confident in what she does. She's coming to us for help. And I've gone through this a little bit in November, and I'm not going to do this today, but really just to kind of run through a case quickly. I want you to see that when I look at that face, I'm looking at everything. I'm looking at her eye position. I'm looking at what the display is, what the dominant and non-dominant sides of her face are, and where I think the teeth really belong in her face. And I have to work through all that process to understand what we can do from a diagnostic point of view. And the eyes never lie to you. What you see in the patient's eyes is usually always telling you the truth, and they're a really important part of our photography and our communication. So I'd ask all our audience, I know you guys can't jump in so easily, but where do you think her teeth belong? Look at her face, look at her smile, and what are you all thinking? And my gut feeling is most of you are thinking, well, we need to lengthen those teeth. And I appreciate that. Yeah, I'm kind of with you. I'd like to lengthen those teeth, but how much? Do you want to lengthen them 1 millimeter or 4 millimeters? Do you want to widen the corridor, or do you want to leave the corridor where it is? And all of these things that you're thinking, we can argue whether we're right or wrong about. You might have a different opinion than me. I might see 2 millimeters and you see 3, and we could discuss that. The problem is we don't know which one is right until we see it in the oral environment. So we really get to see it and evaluate it in the patient's face and what makes her happy. So for me, I follow a set of rules. And for me, the rules are really simple. Every aesthetic case, and I'm not talking function at this moment, every aesthetic case for me is about incisal edge position. Where do I want the teeth to be? Very plain and simple. So rule number 1, treat it like you have an edentulous patient, and where do you want to put the teeth? Never mind where they are at this moment. Where would you like them? How we get there is a whole different process, and that becomes the interdisciplinary part. Do we want to involve orthodontic or ortho or surgical, crown lengthening, or just minor movements and restorative? But all that takes place right from the beginning of those first few photographs. And once I understand where I want the incisal edge position to be, well, that gives me basic information. You all know the average central is about 10 millimeters in length, average. So that means if I know where my incisal edge is, what do I also know? Where I want my gingival architecture to be. And once I have that established, now I can start managing that horizontal plane reference of where I'd like to see the teeth. And for me, that's always step 1 and step 2. Now, I know I skipped the functional component, and I'll get back to that. But the first thing I'm looking for is where do the teeth belong in her face? and I'm not worrying about the functional component to that now. So most of you probably said you'd like to lengthen these teeth, and here's where the communication between you and the technicians that you're working with falters for me. One of the best ways to manage this would probably be for you to composite where you'd like to see that incisal edge position. This way you have a live patient right there with you and you can determine it. But if you're not, if you're sending this to the laboratory and you want them to do that for you, you need to give them information. So if David was sending me this case and David said, you know, Peter, I'd like you to lengthen the teeth 2 millimeters. And I say, okay, David, that's great, but 2 millimeters from where? Because 2 millimeters from the distal of the number 9 or the 2-1 is way different than 2 millimeters from the middle third of that number 8 or the 1-1. And I need that information because I can't guess what your 2 millimeters is. So having reference points of where we want to be is a real big part of the communication, and that's another area where the photography really helps. Now, functionally, of course, I'm concerned with the functional aspect, although I address the aesthetic part first. For me, most of the doctors I work with around the world today are using facial analyzers. I'm really comfortable with the facial analyzer, and of course, we can go into debate about Facebook, facial analyzer, using the auditory meatus or not, a third reference point, and it's a long, drawn-out debate that we don't need to have. What I like about the facial analyzer, it gives me an aesthetic reference and a functional reference, but also I'm comparing that with my photographs. I'm utilizing the photograph of the patient to make sure that that aesthetic reference was transferred accurately. Why do I like the facial analyzer more? Because when the minute you go to a Facebook and you go to using the ear as a reference and then using a third reference point, like a canthus or a Frankfurt plane, you're changing the angulation of the arch. No patient's horizontal plane is that severe as we find it to be with a true ear bow transfer. The facial analyzer gives me more of a horizontal reference, and you can kind of see that on the articulator. You see this cast that I've mounted here, and this cast was mounted with an ear bow. Look at the patient, different patient, but look at her. Do you think her teeth are going that far up posteriorly? They're not. They're sitting more in this direction. So what I'm trying to do is make sure that I get that transfer accurate to the patient's face. And the reason that's important to me is because I'm going to utilize that information across the board. Now, for those of you who aren't Panadent people, you could do this with any articulator today. My friend, another David actually, owns the AD2 company, and he makes the table, the same table that you have for Panadent for every instrument out there today. So it's not limited to one like it was years ago. We used to make our own tables. Now we have the ability to use that in any table. And here's where the beauty comes in. Dr. Hornbrook said to me he wants to lengthen those teeth 2 millimeters from the middle third of the number 8. Well, what did I do? I took my platform and I dropped it down 2 millimeters from that point, and now I started waxing my teeth into place. So now I have a physical horizontal reference of where those teeth need to be. And then I could follow my Curvis B and Curve Wilson to get the shape and form that I'd like to fit into the buccal corridor of that patient's face. I could also manage where I want the gingival to be. So by understanding where the incisal edge is, now I understand where my gingival architecture should be. And all this information can now get transferred back to the rest of my team, and we can start working our way through our final case. So I want to make sure that I started there. And by the way, that's all documented through the photo. Why? Because if I mount this case and I notice that the 9, 10, and 11 are touching my platform in the mounting, I know the transfer is off. And now I have the ability to address that right then and there. So the photography isn't just about the coloration, it's about using it for a diagnostic tool for me.
Yeah.
Once I have...
You might interrupt here. Yeah, I think you made a really good point in that, in taking a photo of the plate. Because, you know, that's something we teach in all our live patient courses, because I know as many cases you've done, you've had cases where you think, this just doesn't seem right. And the doctor, and it could be the last part of his procedure or his or her, or the end of their day, and their plate is canted, because the importance of that plate is, as you talked about, is to be parallel to either pupillary line or perpendicular to the long axis of the face. And you need to see that photo, because I know for a fact that, again, that you probably looked at a photo and said, that's wrong, right? It's not really where it needs to be. And you're counting on that to be parallel to the interpupillary line, basically.
Yeah, so it's a great point to jump in on. So let me say two things about that. One, I'm not an interpupillary line fan. I'm not a fan of using the interpupillary line as a reference. So my studies that I've seen and what I see in the average patient, about 80-something% of people do not have a horizontal interpupillary line. So for me, the interpupillary line kind of goes out the window. And I went back on the slides to show that. Look at this particular patient. Look at her interpupillary line. It wouldn't work. If I followed it, I actually had a case I was going to put in where I did a wax up to the interpupillary line, and then I did another wax up without it to the horizontal plane. And if you watch what it looked like at the end, it was really kind of crazy. So personally, I like to use horizontal reference more than anything. But to your point, I could tell you there are many times where a doctor takes a horizontal plane reference, our face bow, and by the time I get it and I look at it in the mounting and I have the articulation in front of me, I realize that it's off. And now we have a few things that we could do. And this is kind of the beauty of the photography, though, is where I really like it. I don't need to send it back to you most of the time. Really what I'm going to do is I'm going to look at what I see in that photograph of the patient, and I'm going to make the adjustment. So like in this particular scenario, it should be really almost common sense to you that the first point of contact is going to be what? It's probably going to be the 6 or maybe back here on the 3. That should really be your first point of contact. So if I get my Facebook transfer and I'm noticing that I'm closed here or I'm not getting the exact same position, I don't need to send it back to you. I'm going to tweak it right then and there on the table and get it back to the same reference. Again, if it's a full mouth rehab, I'm more than fine with that. I don't know how you would feel about that, David, but I feel more than comfortable that I can make that tweak at that point with the photographic information. And in provisionals, if I was off, it's so minute that we can address that for the next part.
Yeah, no, I totally agree. And I like the feedback from the ceramics because whether it be a stick bite, whether it be the face bow, whether it be a plate, I mean, whatever it is, we make mistakes sometimes. And it's kind of nice when a ceramist will call you out on it and say, you know, I'm looking at this photo and I think we need to make these little changes. So I compensated in the wax up. I mean, that's what we want from you, right? From you as a ceramist.
Yeah, and I think that's quite important. Listen, I can't tell you how many times I've worked on a case and we've followed every step that we should, right? Every transfer, every provisional. And then after I make the final restorations and I have matrices and indexes and I think I got everything perfect, and the doctor tries it in the mouth to evaluate it, and we're like, that midline looks a hair off, and that inside the lid should be a hair longer, or one side should be. And honestly, for me, that's the best of both worlds, because now I can see what I have in my hand on the cast in the patient's mouth, and now those changes are a lot easier for me to really kind of manage my way through it. I did leave out the occlusal concept here. And the only reason I did, because step 1 and step 2 is really about the incisal edge and the plane. Once I've established where we want those teeth to be, then it becomes functional for me. And for me, functional is really about the envelope. I really want to make sure that I'm not constricting those lower teeth. If it has to be an OVD case, then we manage the OVD. If it has to be an orthodontic case where we're moving teeth in and out, then we'll make those considerations. But for me, I address the aesthetic part first, and then the functional part really through envelope and where the teeth belong underneath my aesthetic plane or underneath the anterior teeth. So in this case with Ella, again, such a sweetheart of a woman, we did an aesthetic evaluation. So I did a quick diagnostic wax up. Dr. Bernadette placed this in the patient's mouth. And I think, to me, this shot is like the $1 million shot, right? Look at what that patient looks like with bisacryl on their teeth. I mean, you couldn't see a happier person. And all she wanted to know that day is, when can I have this finished? When can I get to look like this again? Because this is what I want to look like. And, you know, we talk about, and I'm going to talk about the camera details and all the little important aspects of color and value. But for me, that's the most important thing we could have. When you have a patient that feels that way and looks that way, they love you, they trust you, and they want to work with you. And these are the little aspects of photography that I think we overlook. From the lab point of view, these were 28 single unit zirconia restorations. I'm just showing you my zirconia design here for the technician people out there who like to understand how we manage our materials underneath sometimes. But trying to get support and light reflection from inside the structures, not just on the outside. And then obviously these were layered zirconia materials, full mouth rehab. I made some twists and turns on the teeth. I didn't keep everything straight. This is a Dr. Bernadette case, and I tease her, I guess, by saying, she jokes and says, my patients pay me a lot of money to make their teeth straight, and I pay Peter a lot of money to make them crooked again. And I think part of the process is not always having the perfect look, is fitting the look to that patient's face and what looks right in their face. And this patient was very amicable to allow me to make some tweaks and changes and do what we want. I think we're happy with the tissue. I know it doesn't look great to you guys. She had gone through cancer treatments and a lot of stuff going on there. But in the end, I think that was where it really finished up in a happy camper of a patient. So all those little details matter. And then the final photography, right? Because the final photography is what gives you that feeling of reward, of what it changes. Look at her eyes before and look at her eyes after. Look at how you change that person's life. And I think, you know, from the last lecture we did, David, I talked a lot about these patients are your mother, your brother, your father, your sister. That's your mom. That's somebody's mom that we just did that for. And we don't have enough of a reward or a pat on the back for all the good. We're really good at beating each other up about the things we've missed, but not enough about all the things that we've done well. And in cases like this, when you see happy patients, it makes my day and it makes me move through things quicker. So let's get into photography and understanding nature a little bit. Not only is it about the full face and understanding positioning, but I also want you to understand teeth. And teeth are a work of art. And I think like any art form, we need to study them. We really need to evaluate what they look like. And look at each of these teeth and notice how different the values are, the translucencies on the cervical, how much mamelon type structures or warm amber colors that flow through here, and yet how each one is so different. Surface typography, different heights of contour, different ins and outs, and that rigidity of the tooth. And every tooth that I look at has some different aspect to it. And this is why it's so challenging for us to really understand how to communicate all these things, where the photography really comes in handy for us. Now, for those of you who watched the November lecture, you'll notice that teeth, although I'm telling you are all natural, are not. Half of them are real, half of them are fake. And you guys can probably see the difference between which ones those are. But the key to the success with any of these is the same. It's really about how we communicate the information. And I'd love to pretend that I get great photographs and I make single centrals and they work every time, but I'd be lying to you. I think we're getting a better and better track record with some of the tools and some of the processes that I'm going to show you today. But in the end, there's still a 2, sometimes a 3, but we try to get them into a 2-visit meeting at this point. Although I think that's getting better. You know, I think one of my doctors put one in last week, 1 visit, home run, and somebody else put a single central in today, needs a little tweak. So maybe we're 50-50 today, where years ago it was 70-30. We're getting closer to a better spot. But when you look at these individual teeth, part of our job is to make them fit into the environment that they're in. And that environment that we're in is important to us to manage the information transfer, but also how we manage the space that we have to work with. Obviously, in today's dental world, everything is about really being as minimal as possible and not prepping teeth if we don't have to, leaving as much healthy tooth structure. And I'm all a fan of that, of course, too. The challenge for that is, how do I fill the space? And this was a no prep veneer that we actually did on a patient. I think it was an AACD case, if I'm not mistaken, for one of my doctor friends, and I believe he passed on it. I'm not sure if this was the case he used or not, but anyway, it was a very minimal space case, and my job was to basically incorporate what I saw with the other teeth in 0.3 of a millimeter. Did I get it right the first time? No, I got it right the second time, and I would argue it's still not right. I know he passed his exam with it, but I would also argue that my surface luster might have been a touch off. I think I over polished a tiny bit. Look at the surface luster on the central. I could have kind of matted that down a little bit more. I think it would have been even a little bit better. So it's not only about the colors, but it's about the surface typography and the lusters that we talk about. But it was also about the information that came in. So notice his shade taking ability. Notice where the shade tabs are. We'll talk about this a little bit more too as we get into the actual camera itself. And across the board, if I'm matching something in minimal space, it becomes critical for me to have as much information as possible. If I jump into, excuse me, if I jump into another tooth, you also notice kind of a similar pattern that happens. I'm looking at another central here. This is actually a central, the other one is a lateral. More difficult. Why was this one more difficult? Because I had to actually match a restoration rather than a natural tooth. And for those of you who don't know, I assume you do, matching somebody else's restoration or even my own is 10 times harder than actually matching a natural tooth, because I don't understand a few things about it. I don't understand how much space the other restoration had, what the prep shade was underneath it, how you cemented it or bonded it in, meaning did you bond it in with a colored cement or translucent? Did you cement it in? Did you use an opaque color or a translucent color? And how did the ceramics work on it? Did they fire it once or 30 times, or paint stain on the outside, or a coloration on the inside? And all those make things much more challenging for us to actually match. So I'd say matching somebody else's restorations or fake teeth is even harder than matching natural teeth. But in the end, it's the same game. Our job is to understand nature, to understand the little details of the chroma, the value areas, and the translucencies that we see, the surface typography, and the light reflections. And if we can start to match those little details, we're going to have a lot more success. And by the way, this is just a side note. Look at the luster on this tooth. I hope you notice it's not shiny. One of my pet peeves is when I hear doctors tell me they want teeth shinier and shinier. That doesn't mean that I shouldn't polish them right. It doesn't mean that I shouldn't have rough areas. No, but teeth are not shiny. Teeth are a flat surface and they have a different luster to them. And part of our job to make the match is matching the proper luster, because a shiny teeth that a lot of us are used to seeing, especially in monolithic world with these glaze pastes that we're using, and you're getting this super high shiny tooth, that's part of the reason the tooth looks like it doesn't match. It doesn't have a similar light reflection or light index to nature. What gives your tooth the shininess is your saliva. It's not how shiny we made the actual tooth itself. So in this particular case, a very minimal space tooth to work in. This was a zirconia substructure that I'm going to make here for this tooth. And my job is now to manage the space that you provided, right? So you're the pharmacist, you're the clinician, I'm the pharmacist. You're telling me what to do, providing me with the amount of space. And my job is to take all that information and fill that space appropriately. More space is not better. Less space is also not great. Ideally, we're in that 0.5 to 1.5 restoration space-wise to work through. And that depends on lots. It depends on full coverage, veneer, good prep shade, bad prep shade, post inside, or staining on the tooth. Each of those affect how much room we need and what materials we need to make those work. And when I say materials, I'm not just talking about the ceramics. I'm talking about zirconias, lithium disilicate, or even the cursor that David doesn't like me to say, but I'm going to say it. Metal. Even metal sometimes is still a very valuable. I still do a lot of metal cases, and I still
always say that, Peter. I have nothing against metal.
What's that? Say that again.
You always say that. I have nothing against metal.
No, I know. I like teasing you. I pretend it's like you're Voldemort. You don't want me to say metal more than 3 times in one preference.
This is your say it as much as you like.
I only said it once or twice. So I won't get to the third one.
You're one of the.
It's still a very viable prosthetic for certain cases. This case, I wound up with zirconia.
You're one of the few ceramists can make a metal supported restoration look like a tooth. I mean, that's the primary problem I have with metal.
Yeah, I appreciate that, and maybe so. I think again, if I would make the assertion that when we're layering, if we're layering on a white core or a gray core, we still have the same challenge, right? And that's optics and depth. When you're in monolithic world, it's a whole different ballgame. But the minute we're putting brush or ceramic to a substructure, managing the opacity is really about understanding the materials. And I think that's why I spend so much of my life teaching ceramics and layering, because it's still the most valuable part of what we do. And I think it's still what separates us, by the way, from the masses, right? I think you've heard me use the expression before, the McDonald's of cases, right? I don't want us all to be how fast, how strong, and how hard. I want us to be how good can it be. Yeah. And to be honest, monolithics are getting better and better. Some of them look beautiful. Some of the materials are fabulous, but everybody can do them. And if we're all doing the exact same thing, we have no separation, right? And the separation for me is about understanding the materials and when and where to use them.
Yeah, and I think that's an important conversation that every clinician needs to have with their ceramist, because you need different. I mean, if I gave you a 0.5 millimeter reduction, I said I want a PFM, I'd be screwed, right?
Right.
And
I couldn't do it.
And even some of the monolithic, especially in the posterior, and I think that's an important conversation. And this is why you and I get along so well, because you think like a clinician, I think like a ceramist, right? I think it's so important for the clinicians to have that relationship with their ceramist. And you've heard me say this before, but at the end of my lab slip, every single one says, is there anything I could have done better to yield a better result? Or if you'd like change, is there something I could change? I don't really want a call from you to say, hey, you know what, your prep sucks, or you didn't give me enough room, or whatever. But I appreciate the fact that you would call me and say, you know what, you screwed up here, or you could have done something different. And I think for the average clinician that does not have that relationship, and it's going to happen, especially with some of these bigger laboratories, because you can't email or text or call your ceramist. But you want to talk a little bit about that? You know, I know I kind of interrupted your train of thought.
No, you're spot on. You're spot on. And I think, look, I can't, you know, maybe years ago, I wanted to be the cowboy all the time and save the day. And as I get a little wiser and smarter, I realize I can't. And if I can't, then we need to know that there's an issue right now and figure out how to manage that. And that management is either you reducing the prep, me reducing the prep, or us thinking through the material option of what's going to work for that particular case. And this is a great example of that, right? Most people think that's an implant there on the number 8, but it's not. And I can tell you, I'm lucky if I had 0.8 of a millimeter to work with on that tooth. Really difficult tooth. So now I have to rethink my zirconia concept. How thick should the zirconia be? Should I use an opacified one or a translucent one? And would I even consider using a lithium disilicate? No, I wouldn't have. It would have been a zirconia from me there, because I feel like the value on the lithium disilicate would have never gave me what I wanted. But yeah, I don't want to deviate too far into that. That's lecture number 3 that you'll invite me back for. We'll do material solutions. Different lecture.
Let me look at my calendar.
I'm going for 3. I'm going to get the 3rd one.
No one will ever catch up now. It's a problem.
So that'll be material options. We'll do that one at a later date if you ever invite me back. But the point of this is it wasn't easy, and I didn't get it perfect the first time. I saw the patient the second time, and I was able to actually make a few little tweaks. So that finger that you're seeing there is my finger, illegally inserting that crown in the patient's mouth to evaluate what I see and what I like and what I don't like, and making a few little tweaks. And why was it successful? It wasn't because I only had 0.8 because I'm so good at materials. No, it was really because the value was right, the typography was right, and the light reflection was correct. Those are the things that make it work. Are the colors exactly the same? No, it's not even cemented in there, right? It's just sitting in there at this point. And those are the little details that make things work. But I wouldn't have been able to get there without the photographic information, without seeing that before I ever had the option to actually sit with the patient or work one-on-one with the patient, which, by the way, was after I made the restoration, right? So all that stuff was there. It was just a few little minor tweaks. And I've taken this shot in polarized because we're going to discuss polarized in our camera settings and why this is so important. Because what you'll notice in the polarized is the tooth looks better to me. It actually matches even more in the polarized. And that makes me feel good that I was able to get the ceramic to emulate nature a little bit, because I don't know if I care that every color or every translucency or every detail is exactly the same. What I care is the same is the actual value itself, the internal structure, and then the heights of contour and typography reflecting light the same way. That's where I'm really more concerned. And I'm leading into this because this is why your photography is going to be so important. And this is when I go into talking about your flashing and how you use light, why I'm so specific about this, because if it's not right, I can't get these details. I can't see these details and really understand how to make them work. And I need to understand the gingival chroma and the amount of translucency that's there. I need to understand where the value is, which tends to be in the middle third of that tooth. And I also need to understand what type of effects are happening on the incisal area. But I also, more importantly, want to understand where the light reflects from. And in this photo, I'm getting to see more of the inside of the tooth. This is a polarized photo again, and I will explain that to you. What I'm not getting is any reflection from these teeth. And that's why one of the reasons I actually like the polarized concept, because it gets rid of all the line angles and the reflection and depth, and it allows me to see if the coloration was right and what's inside the tooth. I'll explain that to you a little bit more as we get more into the camera. The other challenge that I see is the shade guide scenario. And by the way, you know, it's funny, I was doing a lecture with one of my prosthodontists years ago, and I, in front of the audience, I think I mentioned Hue Value and chroma and moved on to the next set. And he stopped me in front of the audience and goes, you know, you should explain to them what Hue Value and chroma are. And I said, they're all doctors and prosthodontists. I think they know that. And he looked at me and said, no, they don't. And I said, you know, okay. And I started going through the whole detail of Hue Value and chroma. I'm not going to spend that much time with it today, except to tell you that hue is nothing more than a basic color: red, green, blues, and yellows. And every tooth has different hues to it. We need to understand that. Value is really nothing more than the light that can be absorbed or can be reflected. And I want to kind of harness that point for 1 second. You've been taught that light, or value, I should say, is about white to gray scales. It's not in ceramics. In ceramics, it's about how much light my ceramic can absorb, which lowers the value, or how much light my ceramic can reflect, which raises the value. And for me, that's what I'm always struggling with in value, is how to get the right amount of light reflection without making it look too opacified, and the right amount of light absorption without making it look too low in value. And that's why the material selection becomes very important. And the last one is chroma. The best example I have for that is I take a glass of red wine. It's a burgundy wine, and you can see that great burgundy color popping through. And as I start pouring water into that wine, I'm diluting the chroma. I'm taking away the aspects of it. It's still burgundy, but it doesn't have the same intensity. And it's important for me to be aware of those as I'm communicating this to my partners, or as you're communicating it to your laboratory partners. They need to know. So the concept of just giving them a shade tab, it isn't good enough anymore. You need more than that. And I would argue that shade tabs are nothing but references to give us ideas, to show us what we see and what we don't see. And David, you've probably heard me say, I think I said it when you and I lectured together, you show me any tooth, any human tooth that matches the A1 shade guide perfectly, and I do your crown and bridge work for you for the rest of your life for free. And the answer is, you won't find one. Why? Because they don't exist. There is no such thing as an A1 shade in the patient's mouth. There might be values similar to A1s. There might be values similar to other colors. But dental color is a little bit more specific than just matching. And another pet peeve, I feel like this is more of a, you're my therapist today. Now I'm venting my dental frustrations to you, David, right?
Don't take it out on all your other dentists.
So my other dental peeve is when a doctor says, match the shade guide exactly. I want to jump to the phone and strangle you. Don't say that, right? Because there is no such thing. It doesn't work. The same pet peeve is match 8 and 9 exactly. No, that doesn't exist. They should be really close. They should be twins, but they cannot be exact twins because they will not fit into the face. Different argument, different day. So let's get back to the color. Color, as we know it in dentistry, looks like this little tiny football shape right up here in the corner. So this is the whole world of color that we all work in. And this little tiny football shape is the actual dental color that we have. Let me blow that up for you so you guys can see that a little bit. So here's the color world, and here's our dental color. David, you might know this. What's the #1 remade shade in our world?
I don't know.
Oh, you know, come on. B1.
I would say B0, actually. B1.
I was trying to help you out there. It's actually B1, right? So if you go back and you look at all the remake status and shades that come back for adjustment, it's B1. And the reason for that is because B1 doesn't exist. It doesn't exist in nature. If you actually look at a B1 shade guide, the color scale is outside the dental color zone. So when people make B1 shades, they think it's just whiter and brighter, but it actually goes too much into the yellow-white chromoscope. And because of that, it never looks as real as it should. The second part of that is it's very challenging for a technician to actually make a B1 look like the shade guide B1 based on space and material and selection. So for me, I would tell you, get rid of the B1s. When I hear B1, I say, no, you mean you want a 1M1 or you want something a little bit brighter than the A1 or a higher value. We could work through that. The other ones that don't exist are the C and D shades. And I know we've been using them for 20 years. And David, we've joked when we lectured together about the D3 shade is the shade that every doctor picks when they have no idea what the shade is, right? It's kind of like A2, C1, D3. D3 is the one that you need. Yeah. Just put D3 down, right? And D3 is a shade that also doesn't really exist in nature. It has a lot more red in it, and that's why you see it more down at the bottom here, which kind of ties into this area of the color space. C, I've been in many ceramic factories, and just so you know, when we're making a C shade, I throw green oxides into the ceramic. Yes, green, because that's what I need to get the values down. And that's, again, why C shades don't really exist in nature. So I get it. We choose C's and D's and maybe even the bright B's as reference points of what we're looking for, but we're not looking to match the old classic shade guide anymore, because those are not accurate references of what teeth look like. Those are references of value. So for me,
Peter, can I interrupt you here?
Yes, please.
Because this is something I don't have the answer for. Not that I have the answer for anything else, but that you might working with different laboratories. So, you know, in the field of clinical dentistry, you know, the manufacturers with their composites have created like chroma was a good first good example, where a composite will take in all the colors of the adjacent teeth, and you can use literally a single shade of composite. You get a pretty nice result, especially on posterior teeth, right? Where in the past, if you put a B1 in an A1 tooth, it wasn't even close, right? Are the manufacturers, or is there an opportunity with ceramics that they will have this ability to pull color from around it or mimic color from around it, and you might have like a single porcelain?
So they try. The problem with it is this. Composites by nature, which are 80% filler and 20% ceramics, have a much better optical property than ceramic materials. So because of their optical nature, their refractive index and their ability to absorb and reflect color, in general, you can make composites look much better than a natural tooth if you want to spend the 6 hours layering one composite or 30 composites. I've seen composites that I would have never known they were composites. At least the first year, maybe 2 years later or 3 years later, you could tell they're a composite. But optically, they're a better material. So not to deviate too much, David, but what I would say to you is that's why when I'm doing the long-term provisional on a white and pink case, where I'm doing white and pink gingiva, I always make the pink composite off. I always make it darker or lighter or funky looking. Why? Because if I make the pink composite look as great as I want it to look, I'll never get my ceramic to look as good. Yeah. Optically, it's a much better material and much more forgiving for you. So intraoral, no, we don't have that. And I don't want to be corrective to what you're saying. I would just make the argument that teeth don't really pick up the color of the adjacent tooth next to it the way we kind of act like they do, right? We kind of act like, well, I put some translucency here and it picks up the color of the tooth next to it. No, it doesn't. It's its own entity, and it will pick up the internal color that you're getting. So if I have a good prep shade or something to work with and I'm using composite, I'm going to get some of that coloration to come through. Just like a veneer, by the way, right? I give you a ceramic veneer, you open the box and you say, wow, they look like they're too white. I asked for 1M1 and these look like they're OM3. but then you put them in the mouth, and the bonding and the metamerism brings the color through from underneath. So in that area, it works. In full coverage and larger spaces, not the same.
Yeah, so I'm going to tell you something interesting, and maybe you've heard this before. So I had it when Emax first came out. It's been on the market 15 years, right? You know, I did a lateral. So single lateral, photograph the heck out of it, right? A lateral and essential, so 8, 9, and 10. And so on the model, they were exactly the same. I put them to place, and 10 was like great, like really great. So I pull them back out. They look the same. Try and gels. Everything was great. And it turned out there was a PFM on 11, and the metal lingual collar, that number 10, that Emax pulled that metal lingual. So if I took a business card and put it between 10 and 11, 10 was perfect. If I pulled it back out, it pulled in that gray. So I looked at that. I thought, is it cheaper for me to keep sending this back, or just like do number 11 for like free? So we end up doing 11. So, you know, I'm sure that some of the clinicians listening, and even the ceramists, have had that problem where, especially lithium disilicate, because it'll pull gray from patient teeth. And
lithium disilicate by nature is low in value, right? Yeah. So, and again, we'll save that for material selections, but
go ahead.
Material selection to me is such a critical aspect, because, you know, I hear it all the time, right? I get doctors from all around the world who want me to do a case for them, and then they say, and can you do it in lithium disilicate? And I'm like, well, why? What's the case? Like, why are you picking the material before we know all the information? The material doesn't drive the case drives the material. But again, we'll shelf that for free.
Another time. Thanks.
So let's look at our shade guide quick. I don't know if you guys are aware of this, but when you look at a shade guide, you know what the reason that the shade guide isn't a gray holder? I'm challenging all your thoughts today, David. Do you know why it's in a gray holder?
No, I'm going to let you tell us.
So believe it or not, this was supposed to be 18% gray. And back in the 1940s, when they made these shade guides, the reason it was 18% gray is because the retina is a muscle. And just like any other muscle, the retina fatigues. Although your eye muscle fatigues quicker. Usually it's 8 to 15 seconds, depending on if you're male and female. Men leave fatigue quicker. Women see color better. And the reason that they wanted you to have 18% gray there is because what they wanted you to do is put the shade guide next to the patient's teeth and then drop your eyes down to the gray, because the 18% gray relaxes the retina or the muscle. The problem is that's not 18% gray. They thought it was in the 1940s, but realized years later that that really wasn't a pure 18% gray. So that's one reason that I'm against the classic guide. The other reason is I think there's only about 4 or 5 shades that are valuable to me for communication. I've kind of shifted everything to the 3D guide or the linear guide. But with that 3D guide, I want to be clear, you need to understand, what am I looking for? I'm looking for nature. Nature has chroma in the cervical, value in the middle third, and translucency or age, depending on the effects that we're trying to represent for that patient. So when I build ceramics, I'm building them the same way: chroma, value, and age. The same process over and over again. And again, I don't want to go off into material, but I will tell you, this is where the flaw is with a lot of the multi-layered monolithic zirconia materials today. When we talk about it's got 3 different chromas to it, it doesn't really. It has, based on the classic Vita guide, a different chroma saturation, and I'll show you what that means, but let me get to it. Here is what 18% gray looks like today. This is the most forgiving color for the eye, and it actually relaxes the retina. And the new linear guide actually has more of an 18% gray on the base. And you'll also notice up in the corner, I have an 18% gray card, which I don't really use anymore because I don't have to calibrate my computers the way I used to, and I don't really need it, but I still have it there because I'm Italian and I'm superstitious. So the minute I take it away, everything will fail. So it stays there forever. When I mentioned the 3D guide, I don't like this one. Throw that one away if you have it. I like the linear guide. The reason I like the linear guide is because the linear guide actually has a very simple system to it. Step 1, give me the value. Am I in the 0, 1, 2, 3, 4, or 5 range? And once I know what the value is and I can drop my eye down to relax it, Let's say I'm taking David's teeth and I look at them and I say, oh, you know what? You fall into the 2M family. Step 1 is done. I go down to my 2 guide, and now I decide, is David in the 2 family more in the yellowish range or more in the reddish range? And what's the difference? Yellow is more light reflective, red is more light absorbing. So it's a really simple 2-step process that I think is much more helpful for me to be communicating the shades with the patients and for the doctors to send the shades to the laboratories. So step 1, like I said, I'm going to find out the value. Step 2, I'm going to understand if it's more in the yellow or the red world, and if it's more light reflected or more light absorbing for me. Once I have that information, I'm going to go to my polarized photograph. And again, I'll explain to you what the polarized done more in a minute, but you can see how it's flattened out. You don't really see any light reflections or any information there. This was a really challenging case. It's probably about 5 years old, so I'm not very happy with it, to be honest with you. But in the end, I had to manage a very wide space and try to make it look narrower because we didn't do a window veneer here like we discussed possibly doing. But in the end, I think it works. I'll show you the flaws of it, by the way, because I was upset that the doctor actually cemented it on the first visit. Look at the patient's eyes again. The photography helps. And here is his natural tooth. Here's the final restoration. I remember what I said to you when I showed you the other restoration before. I said, really what makes the restoration work is the value, surface typography, and light reflection. What's the flaw with this restoration? Surface typography. My mistake, I over-polished it at the end. By the way, I put all those details in. I spent an hour on my microscope getting every little dot and everything I needed in there. And then I looked at the clock and it was midnight and the driver comes to pick up the case from my lab at 12:30 at night in my hallway. And I had to polish that thing as fast as I could. And I polished the heck out of it. And I took away all that little surface texture and detail. When the doctor sent me that picture, the first thing I said was, oh, it looks good. Send it back to me and I'll touch up the typography. And he said, oh, no. The patient liked it. I cemented it and it's done. So it goes in and it is what it is. I couldn't get a second touch of that. But the good news is look at it under a polarized. Look at the values and how similar everything is without all the surface reflection and all the details. So getting that polarized does help us to really see the internal details. When you're taking pictures, doctors, never, never, never do I want to see you taking photographs with the patient in a chair. You need to set up areas in your offices where the patient is out of the chair, sitting or standing against the wall, so they have a flat reference to rest their back on, not in the chair. I could tell you've taken a chair picture instantaneously, and they're always off. The angle is a slight bit, even if you sit the patient up in the chair, no good. So let's get them out of the chair for our photography. Second thing is, I always want you taller than the patient. So if you're shorter than the patient, have them sit and get your camera angle to be not shooting up at the patient. This is no good. I want your camera angle to be up higher so the flat of the lens is flat to the actual fulcrum of the lip or the flat to the facial aspect of the tooth. If you're not sure, a little higher is better than being too up at your angle. That angle really matters a lot in the transfer of the color communication. Just to prove my point, this is a patient sitting down in the chair and the doctor taking a few photographs. And this is the same patient standing up with the same camera, same day, same everything. And look at the difference when I compare the two photographs. Patient back in the chair, patient sitting up. If I'm the lab technician and I'm working on this, my brain tells me that tooth looks kind of short. It seems like it has this ambery yellow hue to it. And I'm not reading it the right way. I need the light reflection and the angulation to be proper. Otherwise, I'm never going to be able to match what I see in that photograph. And another reference point, your shade tabs should always be edge to edge with the tooth. Never do you put the shade tab on top of the tooth or in the edentulous space. Always edge to edge because the eye sees color better in vertical lines, not in the horizontal. So I want to kind of capture that information, keep the plane of the shade tab in the same plane as the tooth with the same plane of the camera head, always the same all the time. Okay, so let's run through some of the basics with the cameras. I don't want to spend too much time here, but I think this is what David really asked me to do. There are lots of different types of cameras out there to use today. I'm just starting to experiment with the mirrorless cameras, so I don't want to tell you they're perfect yet. They have a lot of great things to them. The flaw is they don't really have all the components we need as far as lenses and lighting right now, but the bodies are fabulous, and I think they will be our future in the next few years down the road. I'm kind of working with DSL cameras, and I'm using full frame cameras. And no, the iPhone is not a dental camera. I hate to break that to you. I know everybody thinks they have a great iPhone and that's what they can use. So let me explain to you that the iPhone is not a dental camera and is not the camera of choice. What the iPhone is really, really good for are for you to take pictures of your meals and post them on Instagram to show your friends what you ate for dinner or how great dessert was or how great you looked in that suit jacket, but it's not a dental camera. So please stop telling me I just took an iPhone picture because that's all I have. You need a dental camera. Which one should you get? Well, I'm going to say that years ago, there was a big debate between half frame and full frame. Obviously, the half frame is half the cost, and the full frame is a lot more expensive. Years ago, I didn't really care. And actually, most of the photographs that you see in my lectures, probably from 4 years back, are all half frame photos. Today, I only shoot with full frames. And I kind of encourage you really just to go straight to full frame at this point. Why? They're more cost effective. And I think you can see by the photograph is you have more space to capture information. So you have a larger surface to hold the data of your photograph, and that's better for us in the bigger picture. And they're comparable pricing wise today. I think they're even weeding out the kind of half frames as like the secondary old cameras. So you're not even going to see much of them around anymore down the road. So for me, it's about the full frame. Lenses, you have a lot of options. Notice I'm not saying Nikon or Canon. I don't care which one you use. I'll give you some pointers on that. There's a lot of options for lenses, and I think part of the flaw with the mirrorless cameras are they don't have the lensing we need at this moment or the flashing system. So although they'll be good, they're not really there yet. I've switched my lenses. There are really just two types of lenses that you use in the camera world today. There's either a fixed lens or a variable lens. What's the difference? The fixed lens, the height you have is the height it stays forever. They're also usually much heavier, and they're usually limited in how much you can zoom in or zoom out with. The variable lenses are like an accordion. They open and close, and they have a lot more ability to be much higher in their millimeters or smaller in their millimeters. So you do have more reference with them. And actually, I used a fixed lens for probably 10 straight years. And a few years ago, a good friend of mine from Romania, Milos, who's a fabulous photographer, came here and spent a day or two with me, and he turned me on to these variable lenses, and I went out and bought all of them from all my cameras. So all my cameras right now, whether it's Nikon or Canon, I'm using a Tokina lens. This is actually the older model. They made a newer one right now, but this is a variable lens. It's only about $400. And believe it or not, the lens is more important than the body sometimes. So I would tell you a good lens is key. Don't go for the cheaper, quicker lenses. They don't help you. For the price, this is probably one of the best lenses you'll find for dentistry today, or at least I find that with most of my pictures. Now, why is the lens critical? Most of the photos that we take are at different magnifications, right? So 1:2, 1:1, or 5:1, meaning that we can kind of take the actual size of the object. We could blow the object up as large as we want, or we could kind of make the object smaller by pulling away and going 1:10 or 1:5 and showing the difference in the magnifications. This is actually why I like the variable lenses better, because I have more ability to control some of those spaces and how I make them work. All you really need to know is that when I'm shooting a full face shot, I'm usually about 1:10. And when I'm shooting intraoral, I'm usually 1:3. Now, I want to be honest with you. I pretty much shoot everything intraoral at 1:3. Why? Because in digital world, I don't have to get this 1:1 close-up. It's digital. I have my camera that's usually, and any good camera you buy today is 24, 26, 28 megabytes. The human eye can't detect anything past 12 megabytes. So my point is anything that good of a camera, I don't need to sit there and try to get that great close-up. I could take a 1 to 3 photo, and then I could pull it in or out or crop it in and out. The only flaw of what I'm saying to you at this moment, or the contradiction to that, is if you're shooting for AACD or some of the groups where you need to take raw photos, you can't crop the photo. So that means you actually need to take the 1 to 2 or the 1 to 1 that they recommend. And that means you move the camera in and out a little bit to get the aperture setting that you want, or I should say the focus that you really want. But for me, in general photography, if it's not for exams or printing or something, I'm going to tell you 1 to 3 does everything for you in the digital world, and you can move those photographs in and out. The other problem with some of these lenses, I'm sorry, I'm going quick through this. I want to kind of cover a lot. The other problem with some of these lenses is if you use a fixed lens, I told you you're limited in how much you can zoom in or out. And I want you to see the difference. So look at this great video that this guy, Dan, had done years ago. It's pretty cool. This is the exact same photograph taken with all different lenses. And look what happens, how every lens alters the photograph slightly different. And this is why it's so critical for us to understand that the right lens is really important for us with the camera. For me, I'm going to tell you that I want my lens to fall somewhere between the 80 to 105 range. Anything less than that, it distorts the photograph. Anything more than that is hard to manage. And for me, with the lens that I recommended, the Takina, that lens is actually a 28 to a 105. It's perfect. It has the right range for me to work and get the best photography that I can with it. Too open or too small of a lens, you don't get detail. And too big of a lens, you actually get too much detail and it darkens the photo, okay? So that's for the magnification and the lens. I work everything in my camera on manual. That means I'm shooting everything on M on manual. I set my shutter speed to 125 and my f-stop to f32. Now this is usually confusing to people because they say, but I need it to be different for my face photos, or it's too dark if I use f32. I'm going to tell you I set my camera that I can shoot almost everything on f32 or higher. I actually shoot on f36 or f43 or f48. I move that up. And the reason that I do that is because the higher that number of your f-stop, the smaller the opening is on your camera lens. And the smaller the opening is on the camera lens, the better depth of field you get in your photograph. So I can have a really small opening, f32, f36, f40, and that means that I'm getting the most amount of depth of field on my photograph. The minute I drop below f32, and I go down to 28 or 22, I start losing the depth of field. And you'll also notice the lightness of the picture appears much brighter. The reason it appears brighter is because the larger opening allows more of the outside light into the camera lens. I don't want that to be the case. I think, David, years ago when you used to teach photography things, and I was too, we were talking about, silliness of you want 5,500 Kelvin and you want to shoot your photographs at 10 o'clock and 2 o'clock with northern sunlight. And it was dreamy if you think about it, right? I always joked and said, what if you live in Seattle? That means you can never shoot a good photograph because the light rains there all the time. And, it doesn't make any sense. The goal is to get your camera to control the lighting all the time. Yeah. I could pick up my camera right now over there and I could shoot a picture of my screen and I could turn off all the lights in this room and shoot the same picture. You wouldn't know the difference because the lighting is being controlled by the opening of my lens and how I set the camera up. So I don't want your lighting to be controlled about the temperature outside or where your window is. I want to throw all that out, and I want the camera to control the image, not the other way around.
Yeah, I think it's important too, because I think a lot of people don't understand the flash. I mean, these are computers, right? And the flash is actually compensating. So the camera basically tells the flash how much light to give in order to compensate for that, either lesser light or more light. And the flash will actually cut down or add flash to that based on the information that you provide, right?
Yeah, so it definitely does that if you use the through the lens metering, right, which is the setting inside the camera. Yeah. But I'm telling you to shoot manual, because I'm telling you to shoot manual, that means I'm going to control the amount of distribution. But
you still have the flash on TTL.
Yeah, so I'm letting my f-stop determine how much light should go in. But be realistic that the smaller that I make that opening, it can't give me enough light if I don't change the amount of light that I'm distributing from the base of the camera itself. So I'm going to kind of touch on that a little bit in the flashes, right? Because what I'm trying to do is get the camera set up in a simple way. And you know, for me, David, where I kind of got into this more is as I started shooting more and more photographs, I would try to get my doctors to shoot more and more photographs. And I would go to their offices and make them buy the same camera. And here's where the problem came in. Not every doctor is like you. Not every doctor is like some of the doctors that I work with, where they want to take all their own pictures. They want to get better at what they're doing. They pass it off to somebody in their environment. And where I always joke and say, this is where Marge, who's 97 years old, has been working in that operatory for 38 years, picks up this big heavy camera and has no idea what buttons to hit, and they're moving knobs and they're changing things. I didn't want that to be the case. I want it to be that when you pick up the camera, you turn it on and you hit click.
Yeah.
And I've tried to set my cameras up that way. Again, I can shoot my camera in any lighting, in any environment, and I know it's going to work. But I've done that by internally changing coloration temperatures, ISO settings, and I'm going to touch on that a little bit now, actually, explain that a little bit better, okay? So first off, the speed that I'm using is my shutter speed, and that means that that little f-stop opening that I'm talking about is how long that little opening stays. A little shutter actually closes over that, and when it closes over that, it stops any light from coming in. If I make the shutter go up and down really quick, it doesn't allow any time for light to actually get into the camera. If I make the shutter go up and down really slowly, then more outside light is coming in. So what I want to do is I want to keep that shutter speed fairly quick. I'm shooting at about 125. Now 125 is not that fast, but it's fast enough for a stationary patient. Your patients aren't running and jogging and moving around the room. They're sitting there. So because they're sitting there and you hit that button, you hear click, click, that's your shutter opening and closing. If I had a patient that's moving a lot, maybe they can't sit still and they're kind of doing this, I might increase my shutter speed a little tiny bit to get that click, click to sound more like click, click, to be a little quicker in their opening and closing. But in general, my shutter speed is 125, and that's about where I always need it to be. Okay. The other aspect that are in the better cameras are something called ISO sensitivity. The ISO sensitivity also is the third point of light internal in the camera. And this is where I kind of stopped us with the TTL, right? Because there's a third point of reference that can allow more or less light into the camera, and that's the ISO sensitivity. I'm not going to overcomplicate this for you. I'm going to keep it really simple for you. The ISO sensitivity in Nikon and Canon should always be set to either 100 or 200. 100 in Nikon, 200 in Canon. Any more than that will allow too much light from the outside and what we call, or professional photographers call, dirt. And what that actually means is it's allowing too much of the outside light to come in, and it's creating a dirty mess on the picture. It's not giving you the depth of detail that you need. So keep it simple, 100 for Nikon, 200 for Canon. That's what your ISO should be set to. And the reason I'm being specific about that is because what you'll find in your camera settings is Nikon and Canon shoot a little bit different. Nikon tends to shoot a little colder. Canon tends to shoot a little bit warmer. So because Canon's a little bit warmer, I'm bumping the ISO up a little tiny bit more to balance it. Nikon, I shoot it at 100. Canon, I shoot it at 200. And then the last part of your good camera is your white balance. White balance, you're going to find in most all the cameras today. Years ago, I used to use my grade card, go into the custom camera settings and photograph the grade card and actually use that as setting the white balance for the camera. I don't need to do that anymore. I simply go to my white balance setting and I put it on cloudy. I want to shoot all of them on cloudy. Now, I've had this argument with other people. Some of them like daylight. Maybe. I find cloudy seems to be the best, especially in nighttime. Maybe Nikon, maybe in Canon, daylight works okay, but I find cloudy to be kind of a home run on both sides of the camera for me. So I'm just setting that setting on my white balance to cloudy. And this is the difference when you look at the difference between a properly balanced photograph, the same photograph taken straight out of the box with Canon, and the same photograph taken straight out of the box with Nikon. You can see what starts to happen. The Nikon starts to shift to the colder blue, and the Canon tends to shift to the warmer colors. Our job is out of the box is to adjust those color settings to be right. I may have to tweak my Kelvin from 5500 to 5800 or drop it to 5400. But I do that by experimenting a little bit with the camera body and the flashing. So I've recommended these cameras for a few years now. This is a half frame, the 7200. But honestly, today, you're better off going straight for the 750 or now the 780 is out. If you're going to be in Canon world, the 70D is a half frame. Once you get into the 5Ds or the Mark cameras, those are full frames, great bodies. And I think part of the challenge here, David, that I find, and I'm going to talk about the flashes now, but I don't, again, I'm sorry, I'm using you as psychiatry 101 today. I'm going to vent another frustration.
You haven't gotten out enough in the last 2 years.
You're send me a bill at the end of this, right? For me venting all my frustrations to you. The frustration here is that when you're talking about the price of cameras today, I just want to like hang myself sometimes. When I talk to a doctor, I did a course in Canada a few weeks ago, and I had a group of like 40 doctors and a lab that had brought me there to talk to their doctors. And I kept talking about the importance of the camera. And one guy kept saying to me, well, I have this camera, isn't this good? And I'm like, no, that camera's from 1960 and you need to adjust it. Well, but I bought this one. Can I just get a new lens? And the concept of it was they didn't want to invest in the new camera, right? And I think any good business person knows you as a good business person reinvest in your business constantly. And why it bothers me so much is if you want to buy a new CBT CT scanner, it's 120 grand, right? But when I tell you you need to buy a good camera system that will last you the rest of your life and it's going to cost you about $2,500, people look at me like I'm crazy. Yeah. And I'm like, it's $2,500. I mean, it's a crown. Yeah, get a good camera. Maybe it's 2 crowns, depending on your area. But whatever it is, it's going to last you for the next 3 to 5 years. And I'd also make the argument that as a professional, you should have 2 good cameras, not just one. Because if one goes down, you're not a professional anymore if you can't take photographs that day. Yeah. I'm a 6-person laboratory, David. I have 6 people in my lab. You know how many cameras I have? 8. Yeah. You know why I have 8? Because I want to be a professional. And I'm lazy. And I want to set each camera up to just pick up, shoot, and point. I have one on my desk, one on Jen's desk, one on Keon's desk. And then I have 2 D750s in my closet in my office. You know why? They discontinued the 750, and I like that camera. So I have 2 backups for the next year down the road in case I don't shift out into my mirrorless cameras. I want to be prepared. So you need to always have the equipment you need. But I don't want you to buy 8. All I'm telling you is 1 good camera will be enough for you to run through your practice for the next 5 to 8 years. Spend the $3,000 or $2,500. It's what you need. Don't cheap out. Okay, I'll give you.
I think let me just interject there. The problem that doctors don't want to invest is because they don't use them.
Right.
And if you say, well, you know, I don't do that many single. I mean, I've heard this. I don't do that many single centrals, or I'm not a cosmetic. It's like, dude. You know, I say dude or dude. It's for both sexes, but anyway.
Do that.
Yeah, dudetta and yeah, whatever it is. It's if you use them. You know, Mark Montgomery, who I've lectured with for 25 years, he has a statement that the doctors that take photos do more dentistry. And, they're documenting, they're communicating with their patients. But, when you look at it, $3,000, that's like nothing.
It's a joke for a practice. That's why I'm being sarcastic with it. I'm like, you're kidding me, right? You don't want to get one good $3,000 camera system?
Yeah.
So it's frustrating, like when you hear that. But also, when I was building this lecture, I mean, you kind of challenged me to do something on photography in the last time. That's why I kind of started where I started, right? Because it's easy just to talk about the body, the lens, the flashes, but realistically, the camera is so much more than the single central color. There's so many aspects to us taking these photographs that are priceless, that you cannot compare.
Yeah.
So let's talk about flash. Here's my fourth and my last psychiatrist complaint to you. Okay. This one is about the flash. Listen, camera companies are really great at selling you cameras, but they're not dentists. They don't understand macro color and tooth color. I would argue that as dentists, not enough of us understand tooth color. That's why I went through the B1 and the C4s. So we start to get that in our head. Don't expect the guy from PhotoMed to know dental color. They don't. So let me be clear with how I talk about this. Anytime I attach light to the lens, I have what you call a ring flash. I don't care that there are two of them there. You do not have a dual flash. You have a ring flash. Why? Because it's attached to a ring on your lens. And it's not about the number of lights. It's about the proximity of the light to the lens. Do I sound angry enough as I'm saying this? Because I'm trying to get that New York sarcasm flowing there, David. Does it sound
as a New Yorker, you don't sound very angry.
Okay. I'm trying to portray it.
As an Italian New Yorker, you don't sound angry.
So proximity of the light to the lens is what makes it a ring flash or not the number of lights. I need you to get your flashes off the lens. And by off the lens, I don't mean by attaching them to a bigger bracket on the lens. What I need you to do is get them away from the lens completely. Why? Because I want your light source to come from a 45-degree angle into the patient's mouth, not from a close area to the lens. That's proximity of light. That doesn't help me. So you need a bracket. The only company that really sells the brackets today are photomed.net. And photomed.net, photomed.net is great. I think David could probably tell you the horror stories. I know I went through them and Claren went through them, where we were building our own brackets and trying to get these flashes where we wanted them to be, and it was a nightmare.
Two dental assistants holding flashes.
Yeah, it was a nightmare, right? What we had to go through. So you guys have it easy now. $200, you got the lens, you got the bracket, it holds the flashes, move on. It makes life easy for you. Why is that important? Because I want these flashes to help me control these settings that I put into my camera that I explained to you already. I want to make sure that when I'm taking my pictures, that clinically, I want to make sure that I'm capturing the hue value and chroma, the light reflections, the typography of the surface. And because I have a bracket, I have the ability to move the flashes in if I want to. Why would I want to? Surgical. Maybe you're trying to capture a cyst. Maybe you want to see a little pinpoint of a margin. Maybe you've retracted the tissue and you want to see the bone color. I don't know, but whatever it is you're looking for, surgically, I can move those flashes in. That throws out all the color communication and value for your technician and aesthetic communication, but it's still very useful. So I get the best of both worlds. The minute I'm going to my real communication photography, I'm here. I'm clinical, where my flashes are to the outside of the camera, 45-degree angle. Why? Because I want my light source to come from these angles, from the outside, not from a direct relationship from the flash. I lose the ability to see color. Let me prove this to you, because I've had this argument or discussion, I should say. About 2 years ago, David, John Coyce asked me to do a lecture for the symposium group there. And it's an honor to me. I've lectured with John too, and he's wonderful. And I think highly of him as I do of you. And I thought it was funny though, because when he called me up and asked me to do it, he said, oh, by the way, you know, I don't like the ring, those side flashes. They're too cumbersome. I like to keep them a little bit closer. Plus, I don't want the shadowing in the back of the mouth. So just so you know, I might contradict you if you talk about that. I said, no problem, bring it on. Let's go for it. So I went and did the lecture, and I put this picture on the screen, and I said, John doesn't like this picture because I'm getting shadowing in the back of the mouth. And John's 100% right, because if I wanted to take a picture of how great that second molar was, I can't do it with my flashes here. The problem is, if I take the picture and get great light in the back of the mouth, I've lost the ability to communicate any of the color, shape, morphology, surface typography, and detail that I need for aesthetics. So you need to know why you're taking the photograph. If I'm taking it for a mirror shot for occlusion, or because I want to harness a small pinpoint area, go surgical, move it in. But if I'm looking for color communication, you have to have the flashes to the outside. There is no other way around it. Let's stop trying to pretend we can get the best of both worlds. You get the best of both worlds by having a movable bracket. That's how you get the best of both worlds, not by saying, I don't like it because it's a little bulky. It doesn't work that way. Let me prove it even further. I'm going to take a tooth. See when the light shines from my flashes from the outside compared to the way the light shines from the inside. Watch this when I look at a natural tooth. They're different teeth. I'm sorry, I have to do this again with the same tooth. But notice with my flashes to the outside. Look at this from a communication point of view. I see the chroma. I see the value. I see the translucency. I see the light reflection, the surface typography, all the details that I need. Watch what happens when I move the flashes to the inside. You know what that script says? D3 rush, because you have no idea what the color is or how to manage that color. So at a midpoint, flashes have to be 45-degree angle. I also like tools. I'm not afraid to use any of the tools I can. The only difference is I don't count on the tools first. I use the tools secondly. So what do I mean by that? I take all my pictures, I manage my way through the cases, and then when I'm all done and I've thought it through in my brain, I might grab my easy shade and shoot the tooth. And if the easy shade reads similar to what I already saw, I feel really happy about it. I feel comfortable that I've actually picked the right thing. And if I see something really different, I might have to go back and reevaluate, because computers are usually a little bit more accurate than my eye, especially after a 12-hour day and the patient's walked in here at 7 o'clock at night, and now I'm starting to take color shades, right? So I like the reference of the tools, but I don't want to live and die by them either. A newer tool. Yes,
Peter,
sir.
can I ask you another question? I mean, you're taking some shades for your doctors that are there in New York.
I do.
Yeah. What percentage of the doctors are using Easy Shade that as a communication tool? I mean, let's say I did it. I don't use it, but let's say I did and I sent you that information. How much value is that to you, and what percentage of your doctors are doing that?
So it's a lot of value here is why. I'm sorry to go back to that slide quick. A few things. Again, realize the Easy Shade is a densitometer, right? It just measures color from a specific point of view.
Right.
So it doesn't give me bells and whistles. Doesn't tell me about translucency. Doesn't tell me about any of those things. All it tells me is a specific point, what the appropriate shade or density of that tooth is in that specific point that you photographed it.
Okay.
Now, why is that important? Because it's a reference. You're good with color. You and I have done cases together, and you take fabulous pictures, and that makes it easy. But let's pretend you're colorblind, and the photographs you sent me in the shade tab reference that you gave me are nowhere near what I need it to be. That Easy Shade reference gives me a factual reference to work from, and then it gives me formulation to think through. Wow, he used an A2 shade guide. The Easy Shade is reading A1 value, so that means that I got to increase my value in that middle third, but still get the chroma of the A2 because that's what they're seeing with the patient. It just gives me more information to work with. To answer your question broader, I don't take all the shades from my doctors. Most of them are great photographers today and take their own. I like to see the patients. I used to see 3 patients a day, 2-3 years ago, even because of COVID, not even because of COVID, just because I did. But my doctors have gotten so good with shade taking now, they don't send the patients over as much for me to take the shade. Local doctors send their patients over more because they want me to have interaction with the patient.
Right.
So it's a different dichotomy that's kind of arose from it. And I want to meet the patients and talk to them and explain color and go through all those details with them. I count on my doctors to take pretty good shade shots these days.
Okay, can I ask you another question? I know you got a zillion more slides. So, one thing.
It's your dime.
What's that?
It's your dime. Take as much time as you want.
Yeah, we're going till 10. We're going till 10. You know that. For the listeners, no, we're not going till 10. We got another 30 minutes. So, one thing that you didn't discuss, and I know how you feel about this, you kind of touched on a little bit, is you get that single central back, or it could be any crown, right? You get it in, it doesn't match perfectly. And the doctor sends it back and says, it was too yellow or not bright enough or didn't match, right? No photos.
So, or you suck.
What's that?
Or you suck, they say sometimes.
I'm not paying the bill. So,
you're horrible.
Yeah. So typically as a ceramic, because I don't use this and it fascinates me, but I just haven't got into it. So, let's say you send a single central back to me, right? It was a little bit off. So I would photograph the heck out of it, the crown in the mouth with the polarizing filter and without. So you would say, oh, that's what it's supposed to look like. Okay. How valuable would this easy shade be, especially with your monolithic or even your feldspathic ceramics, where you're kind of guessing on the influence of the dent underneath? I mean, you're guessing a little bit, right? You're a good guesser.
Yeah.
So I get this thing back and it's not perfect. How valuable would it be for me to take the easy shade and show you what your crown looks like on the tooth?
So this is why we're such a good team when we lecture together, right? Because you led me right into where I was going. So this is exactly where I'm going. The easy shade is a densitometer. It measures a space, kind of measures thickness of light passage, and gives me an information. That information is valuable to me. So if you did exactly what you said, if my restoration was off, you put it in the mouth, took a polarized photograph and a densitometer shade, it's probably the best of information I could have up till recently. And up till recently, I'm going to now add to that. Now I'm going to tell you that I'm starting to use other reference points. What the densitometer did was it kind of worked in LAB space, right? So LAB space is mathematical equation of color. And in truth, polarized to me is really maybe the best version of this. So what different people have done, I think McLaren did it years ago with Photoshop, and then Sasha Hine did it with eLab, and everybody's kind of taking formulas and trying to figure out. So this is a newer version of this that I'm starting to work with now. It's called OptiShade. Basically, the way this one works is it's basically taking a densitometer and a polarized photograph at the same time, and it's transferring it into LAB space. So now what happens is, if that shade that crown that I sent you is off, and you take an OptiShade of the tooth next to it and the OptiShade of my tooth, I not only have the new information, I have the LAB numbers. So now I can actually see my chroma was too high or too low, and I can make those adjustments in the restoration, either additively or subtractively. Okay. So I'm not perfect with this yet, by the way. I've only been working with it for about 2 or 3 months now, and I'm just starting to get more and more comfortable with it. But the beauty of it is it works with an iPhone. Similar to the Easy Shade, you calibrate it just like you do every time you take an Easy Shade reference. You spot the tooth where you want. I take the photograph, and then I can actually send that photograph to another program that helps me to measure space and what materials will work best there.
Okay. And you get this through SmileLine?
Yes, SmileLine sells it. Yes, okay. SmileLine sells it. The inventor of it is a guy in Norway, Marat, and Matisse sells it in Italy. Okay. So I don't care where you buy it. I'm being upfront. I'm not perfect with it yet. I'm still kind of working with it and learning all the ins and outs. But for me, again, I told you before, I don't want to be a cowboy and think I could fix everything. I want all the tools I can get to help me. For me, I think this is going to be one of the better tools that's going to come out down the road, and I'm getting better and better with it, because now I can see the comparison of my tooth and the natural tooth, and I can actually get some mathematical formulas about what I should do with it. And also, this is more on the ceramist end, but if you actually took the aftershade of the prep and the adjacent tooth, I can actually import that information into my Matisse software, and that software will help me to pick through what materials I should use. In other words, I could say I'm going to use translucent zirconia, and then the software actually puts that into the edentulous space and then figures out how much space I have to work with and what materials I should use.
Okay. So is cool. It was hard. I have not seen this yet. How big is that little unit that you just showed?
Tiny little thing. It's 3 inches, and it plugs into any iPhone.
Okay. And so that's something that typically the doctor would own, and you would have to buy the software.
So they don't need the software. They just need to buy the look. I think they should have an Easy Shade. I think they should have an OptiShade. I think those are great tools. I haven't forced my doctors to buy the OptiShade yet, and the only reason I haven't is because I need to be the king of it first. And when I feel like I know it in and out in every way, then every doctor that I work with is going to get a call. You're buying one of these, whether I buy it for you and put it on your bill or you get it, because I'm going to want that information as I get better with it. But okay. I think you know me well enough to know I want to walk the walk before I talk the talk, right? I totally get it.
All right, I'm going to ask you two other questions, and you're going to move on. How much is that unit approximately?
I don't know. I think I'm going to guess around $1,500.
Okay, so half the price of a camera. Second is...
I'm going to guess somewhere around there. I don't know, though. So.
Since the second question is, since these docs that are listening, more than likely their lab is not even familiar with us or don't have it. So they would, so let's say I bought it and let's say I was going to send a case to you, but you never heard of it. I would say, Peter, you've got to buy the software for the OptiShade.
Yeah, so the laboratory would have to have the software to utilize it, right? The actual object, listen, I want to be really clear, David. I have no ownership in this product. I have nothing to do with it. I'm not selling it. I make no money from it. I don't care if you buy it or you don't. I'm only giving you all the things that I'm using for color communication at this moment, right? I like an Easy Shade. I'm starting to like the OptiShade. I think the OptiShade will be a future for me, especially when we're talking single centrals, 2 units, 2 laterals, where I really need that information. And I'm going to force my doctors into that, but not until I'm the king of it. When I really know it perfectly, then I'll kind of influence it to everybody else and I'll want them to use it. So yes, the laboratories will have to buy into the Matisse software, and they'll have to understand how to use LAB color space. There'll be lessons. I think a good example of that is Sasha Hine is teaching ELAB, right? People are using ELAB, but they can't really use it unless you buy his software and he comes and teaches you how to use it. Right. This is going to be the exact same scenario. You're going to have to learn how to use it.
Okay. So when you become the king, can you just teach me and make me the prince or something like?
100%. You and I are going to have a nice dinner at one of my favorite places in San Diego, and then we'll hang out and play with Easy Shade all night.
All right.
Or off the shade, I should say.
You got it.
Okay. So let me run through my photo sequence quick here because I don't want to run out of time. I'm going to tell you that you'll notice next to the pictures, I've done little cameras next to them. The reason I did that was because when I'm taking a full face shot, I'm not using any of the flashes that I've just talked about. I'm not using the 45-degree angles or any of those things. All I'm actually doing is using the flash on the camera and putting the setting into P, which I call portrait mode. It actually means priority, but pretend it's portrait. And I'm taking the full face shot in a portrait mode. This way it's easy and I don't have to change any camera settings. Then I go back to my dual flash and I'm taking my facial and dental facial photos all with the same setting across the board on my camera. So this is my basic diagnostic photo series. Also, I want my patient stable. Again, sitting or standing against the wall and their head in the same position. This way, when you take the headshot, Whether you retract them or not, their head position is in the same position all the time. And by the way, if you look at her interpupillary line, not perfect, right? That's a relaxed head position. The other problem I find is with certain patients, they have trouble keeping their head in the same spot. So the little trick that we teach everybody is your glove box is your best friend. Take a glove box, put it behind their head, let them hold the box against the wall. And if they drop the box, ask them if you could borrow their iPhone and put their iPhone on top of the glove box. They won't drop it. They'll hold it there the whole way, and you can take every shot with their head in the exact same position, so it makes it easier for you. This is my photo sequence for basic diagnostics. My facial shot, again, no flashes. I'm using the camera flash itself, not my fancy flashes here. I'm taking full face smile, full face open mouth, Duchenne smile. Duchenne smile is when you make the patient smile as big as they possibly can. The eyes kind of close a little bit, and I'm taking that photograph because I want to understand the lip dynamics. Then I'm usually taking a right and left sagittal photograph, and the last one we call the midnight photograph. What is the midnight photograph? It's basically a Duchenne smile with the patient tilting their head down and looking up at you. Why do I want that? It gives me the incisal edge position to the lower vermilion border. That helps me diagnostically know right away. Do I want to move the teeth back? Do I want to move the teeth in? Do I want to move them up or down? Where are they in relationship to the lower lip line? So those are all my facial shots. Dental facial, repose. Doctors, when you're taking your repose shot, the worst thing you could do is tell patients to relax. That doesn't work. I also don't really agree with the M sounds or the E sounds. I don't find it really works. What I usually do in my first shot is I take a closed mouth shot with my camera, and I look down to see that the balance is right, the color is right, and everything I need. And then as I'm looking through the camera, I tell the patient, hey, you know when you start to fall asleep and that lower jaw of yours starts to open a little bit? And usually as I say that, they do it, and I take the picture. If they don't, I say, I'd like to let your lower jaw just drop a little bit, and then I shoot the photograph. So I want a real natural repose position. And again, topic for a different day, David, but I also don't buy into the 1 to 4 millimeters of incisal display. That's baloney today. It's a bad reference point. Why? Because lip dynamic changes with age, and Restylane and Botox.
Yep.
So because of all of those things, those are not reference points for me anymore. Cuspids are my reference points now for where I want my aesthetic plane to be. Second photograph is the big smile, and then the left and right lateral sides. Those are all my dental facial photographs. And then I go to my dental photographs. These are all retracted. Retracted closed, left and right, occlusal shots, and black background. This to me is everything I need for a basic diagnostic series. And then obviously if it's for a single central or more, then I want more information across the board. I do like the smile line retractors, by the way. Not the retractors, the black and gray backgrounds. I really recommend these. I also recommend using metal retractors from Photomed, not the plastics. The plastics discolor, they look bad. And by the way, in a germ-phobic COVID world, taking those ugly plastic things out of that sterilization bag never looks clean and sanitary to me. So I like using the metal. I don't get the same light reflection or light absorption, which is actually better. Polarize is an additive. The Polarize cost about $500 to buy. So when I gave you a price of about $3,000 for the camera, I was including the Polarize, depending on which body you buy into it. You can get a great camera system with your brackets and flash for about $2,200 to $2,500 now. Add in the Polarize, you're up to about $3,000, okay? What does the Polarize actually do? It does nothing more than flatten the scope of what the photograph is taking. So here are teeth with shade guides without a polarized lens. Look at the light reflection. Look how you see the bounces and the highs and lows. When I bring this under a polarized flash, notice how flat the tooth look. And again, I know David's getting excited right now because he's thinking ceramics like I am. And what he's looking at is, wow, look at the density around that cervical third up into the middle third of the tooth. And that could be my opacified material, my reflective materials. Look at the translucencies and how much translucency come up and down these teeth. And by the way, these white calcifications that are here, I didn't know where they were here. Now I know exactly where they are. They're on the surface. That means if I'm building this case, I'm putting those white calcifications more towards the outside of my restoration, not on the inside of the restoration. So the Polaroid is just another great tool to give me more information, which is really, David, why I like that OptiShade concept, because it's kind of using the polarized photograph to give you all the information. It really works well.
Yeah. Do you mind if I add something to that?
Sure.
Because I am a huge polarized fan. The other time I really use it, and I think certainly all the clinicians and the ceramists can relate to this, you try in that single tooth, especially with implant crowns. You try it in, it looks great with, you know, your loop light, your operatory light, and you cement it, and the patient calls and says in lower light. So I try these in with Tri-N-Gel or glycerin. I take a polarized shot. Sometimes when that thing looks freaking amazing with my loop light and the light, I take the polarizing filter and it's like, it's not even freaking close. I mean, the value is so far off. And so I nip it in the bud.
That's exactly why I showed you those cases where I showed you the polarized shot at the end is when I know I'm right or wrong. And in truth, I feel cocky when the polarized matches, even if in the face the tooth doesn't look as good as it should. I feel like I did the job the right way, right? I feel like I got all the information right.
I totally agree. But with Tri-N-Gels or even glycerin as a Tri-N, I mean, those are going to keep those from being cut off in the future, because the patient says, yeah, in my bathroom, it looks dark, or low lighting, it looks dark. So, all
right, so let's run through these last few, tie this together. So when I'm talking about teeth, again, the photography, these are old pictures, but the photography helps me, right? Young girl, this is actually Sarah from Modern Family. I did her teeth a long time ago. She wanted a full mouth of veneers, and at 18, we didn't want to do that. So we did everything that I just talked about. We looked at the face. We looked at where the teeth are. We looked about what we could and couldn't do. And we used the photographic information to decide that we didn't want to do a lot. What we really wanted to do was orthodontically move her tooth to tooth, make a few small window veneers, and make it easy for her without having to really do crazy amounts of dentistry. And I think that's kind of the key with the diagnostic tool, or the camera as a diagnostic tool, is being able to do that. And I worked that through with all my cases. This is Michelle. Michelle was a famous actress and model, still is. But notice all her famous pictures here. None of them is she showing teeth, right? So here's a top actress and a model who doesn't show teeth. Well, why? Because she was uncomfortable with them. And when you look at Michelle's teeth smiling or talking, you don't really notice it, all the things that she liked or didn't like. But when you see her not dressed up and you can start to see the little flaws and some bonding on her teeth, we start doing the same thing. Where do the teeth belong in her face? What do we want to change? Do we want to widen, change, shorten, raise? I want to treat it like I'm treating a dentulous patient and what I want to change. And sometimes what you want to change is almost nothing, right? In a case like this, when I evaluated where her teeth were, what I really realized is, besides for the functional concern that we addressed, I didn't want to do much, right? I wanted to maybe add half a millimeter to some of the teeth back, change some of the angulations, very minimal. And I'll do that by working through the diagnostic wax up. And again, remember the diagnostics, I'm looking at the face, dominant, non-dominant sides. So in this particular case, if I take my wax up on the patient's right and I flip it over to the patient's left, it shouldn't be the same. Another flaw with the digital world, right? We're taking molds of teeth and putting them into the face without imagining what the face could or should look like based on the features that we have. So we'll make her veneers. I think I made her 12 veneers, if I'm not mistaken. We did an evaluation back then to test it and make sure it was good. We never finished her lower. She's been having babies and making movies since then. But in the end, I think it worked out well, and we didn't change who she was very much. We just improved it. So now she can feel comfortable to smile and see what she looks like across the board. When I see patients, I'm only showing you this because I would like the doctors to do this more often. I spend 15 minutes to a half hour with my patients when I get to see them, going through color, tooth position, translucency, and all those details. I charge my doctors for that. It's a half hour of my time. And the reason I do that is because it helps me manage the importance of what the patient wants. And it also helps me to meet them and communicate back and forth what I can and can't do. And also helps to show them natural teeth. So I don't care if they bring me pictures. Sometimes they bring me pictures. I'm like, oh yeah, I made that teeth. I didn't make those. What do you like about this? What do you like about that? And I want to see the things they like and don't like. But I also want them to understand what teeth look like. And I usually start by showing them real teeth. These are natural teeth, by the way. And I'll usually say, hey, do you notice by the gum line up here, by this pink tissue, that the teeth actually look a little bit warmer here? And I specifically use the word warmer. I don't use orange or browns or yellows because those words turn them off. I say warm. And when I move this bar down and you look at the teeth in the middle, you're going to notice that this is where the teeth are the brightest. And that's what we call value. And when I move that bar away and you look at the edge, this is what we call the incisal edge. And you'll notice the translucencies and the little fingers that flow through here. These are what make teeth look youthful. And I choose my words very cautiously with my patients for that reason, because I want them to understand what I see teeth as. And by the way, as I'm showing them this, if I see that glazed look in their eye and all they want to do is tell me how white and straight they want them, I've learned to stop and say, okay, white and straight is what you want. I'm not changing your mind. But today, I find about 90% of the patients get so interested in this process that most of their comments are, wow, I didn't know there were so many details. That's so interesting. I want them to look healthy and younger, but I don't want them to look fake. I would like brighter. I like this. So it's a great way to start communicating that process with your patients. And more doctors should be doing that in the office before you're sending information to the laboratory. I also go through wear and rotations. I try to go through a whole detail with them. I also talk about gingival augmentation. You know, Miss Jones, I'm making you a number 9, just so you know, no matter how good I make it, it'll never look the same as 8. Why? Because it's smaller. This one appears bigger. It's always going to appear brighter. Would you like to have a gingival graft here or some crown lengthening here so we can get them to be the same? And I got to be honest with you, a lot of times when I say these things to patients, you know what they say to me? Oh, wow, the doctor didn't tell me that. And I think, well, why didn't they? Because that's part of our job, is to communicate all what we can do with the patient ahead of time. So you get the idea. Also, when I'm making teeth, I also talk about personality. David, we did a great study at the center, the Coit Center, a few years back, where we took pictures of 100 teeth with no faces on them. All you could see was teeth, right? And you've probably seen these studies too over the years. And we showed the teeth on the screen to everybody, and we made them write down if they thought it was male or female. The end result was, it was 50-50. Nobody could tell. Everybody guessed wrong or right. Nobody knew if it was male or female teeth. And the point of that conversation is, what I would say, what I've seen over the years is, men predominantly need more rough or stronger dominant type teeth. When you put feminine looking teeth into men, it usually doesn't help their facial features. Women, on the other hand, can and should have both. You could either have very feminine teeth or very masculine teeth. Both of those can work in your face. So I find, for me, I like the more masculine teeth a lot of times, especially in women. It helps the face. Where in men, I don't want too much of the feminine tooth. It usually doesn't help the face. What do I mean by that? The incisal edge position of the 8 and 9, the amount of embrasure space, the amount of translucencies, is really what sets the tone for the age of the patient. The laterals tend to set the gender, meaning rounder tend to look more feminine, squarer tend to look more masculine. Figure out which one is better for your patient. And the cuspids are more about personality. A sharper, bigger embrasure space tends to appear more aggressive. Flatten that out, close the embrasure space, a little bit more of a softer look. So you have to pick the right look for the patient and understand what's right for them. Let's put this all together. So facially, patient presents. Facial, dental facial, and dental photographs. You can see the flaws. She's 28, but she looks like she's 18. Why? Because of the spaces. They don't work for her. So we're going to evaluate all the things that we just talked about. And from that evaluation, we're going to make a stone cast. I'm going to do a diagnostic wax up, all additive. We're going to try not to prep these teeth too much, very little if we can. And additive wax ups. We were considering making window veneers on the cuspids. I think we actually wound up bringing it around to the posterior, to the distal of the cuspids. I make a very specific transfer tray in my aesthetic evaluation. And actually, I always think of you, David, when I make these trays, because I call these the tack and wave trays, right? I always think of David saying tack and wave, tack and wave. But the beauty of them is my tray is translucent, right? So that means I have a soft PVS liner inside that's also clear and a hard outside that's clear. So when you put that into the mouth with bisacryl or composite, you could tack and wave right through it. You could then remove the hard outer tray and have a soft liner that you can really cure if you're using composite. The importance of that is that you have more stability in making the aesthetic transfers. So here's our aesthetic evaluation. Again, I don't want to deviate because we're running out of time, but notice I'm not calling this the bad word. What's the bad word? Mock-up. Don't use the word mock-up. The word mock means to make fun of. Patients don't know what mock means. We do aesthetic evaluations on our patients. We transfer our wax-ups to evaluate our vision of what we think that patient can have. And because we have the word aesthetic and evaluation, it's freedom for you to make a mistake. You evaluated it. If you evaluated it too long or too short, we can go back and address that. So get rid of the word mock-up from your vocabulary. We use the APT technique as documented by so many great people, Gorell and everybody over the years. David teaches this. I think everybody's kind of taught this over the years, and you get the concept, so I'm not going to walk you guys through that. We're going to put our aesthetic evaluation in. Obviously, we're taking photographs the whole way through. We didn't do a lot of prep on her teeth. She's young, she's healthy. The teeth are really just about aesthetics and color. At this point, we're taking our shade photographs, just like we talked about. Obviously, a little more detail in the diagnostic photos. I want to get the lower incisal teeth. I want to work on the bicuspid so I can really evaluate the teeth in her mouth. I don't want the 6 to jump out and look bad with the posteriors. I think, David, you know, I don't really like to do 6s. I'd rather do 2, 4, 8, 10s. I don't really like 6, but
yeah, 4, 8, or 10 is what we say.
Yeah, I don't really like doing the 6s, but you get it. So here's our final 10th day photographs. Patient goes home with a 10. She feels comfortable. We're going to make some little thin window veneers for the patient. Those are all refractory veneers, some translucency, some embrasure space, a little rounded, so she has some feminine looking, but yet a little aggressive cuspage because she already had that. All thin micro veneers, basically. Tissue looks pretty healthy on insert, and we'll put those in. And there's our patient from the before and after point of view. So I think you guys get the concept of how important this photography is. And I always say the eyes never lie, right? Look at how she feels and the difference of how she kind of feels there at the end. It's the same for me with every case, so I don't want to really go through any more cases. This patient wanted a longer incisal edge position, right? So what did we actually do? Exactly what we just said. A little composite very early in the beginning so we could just establish where the patient should be. We used all the same tools, shade taking abilities, looking at the pupillary lines like David talked about, facial features, provisionalize, get the length. I did a feldspathic case, another layered ceramic case on this, built everything up and finalized it. I would argue that we shouldn't have lengthened this patient's teeth, even though that's what she wanted. She wanted white and bright, and we gave it to her. I don't know if you guys ever saw the Kyle Stanley video where he has a technique now where he actually takes the lip and instead of making the teeth longer, so you get that display that everybody talks about, he actually moves the lip up. So that gives you the display that you want instead, which I would argue in some cases is better than restoring all the teeth. It gives you that 1 to 4 millimeters of display that people seem to want or think makes them aesthetic. Okay, so we're running out of time here. I want to just finish up by saying I choose my materials differently. I don't just pick lithium disilicate or metal or zirconia. I work my way through all the materials. And I'll just leave you with this last case that was a variety of many materials. This is a technician that I actually worked on with Dr. Bernadette here on Staten Island. It was a full mouth rehab. And you're going to notice all the details, right? She got some dark prep, some awkward spacing, very short interdental space we have to manage. And this is all this photographic diagnostic process is what's making us think about what is the right material and what is the right option for us. None of this worked without fabulous impression taking. So I don't care if you're a digital person or an analog person, if you can't manage your cord and your tissue, we can't work. I need your help in that. That's a partnership. And I'm lucky that most of the doctors I work with take impressions that look like this all the time. These are actually all Bernadette's impressions. Every impression she takes is almost fabulous. So it's always perfection for us. I get to choose the materials that I want to use. And I only threw this case in at the end, David, so I just wanted to say that when you look at a case like this that I think was a fairly successful case, actually the patient was here yesterday. She pops in like every 3 weeks and brings wine and cookies and candies. She's a wonderful lady. She's a technician friend. She's one of my students. All this information that goes in here really only matters when we can see it intraoral, when the tissue surrounds it and how it works and if it looks good. And that's what all the photography work that goes into this is really all about. It's a diagnostic process, knowing what materials to use and when to use them, and evaluating the final. And just so you guys know, I used 5 different materials on this case, including, it's going to be the 3rd time I say it, David, Voldemort, metal ceramic. I use metal ceramic at the end. So I use metal ceramic, zirconia, fully layered, micro layered, a few lithium disilicates, and feldspathic veneers. I mixed them all because we're crazy. And sometimes that's what this patient needed based on all the information. So under polarized, I hope you notice that they all match fairly well. Considering that it's zirconia, metal, and feldspathic, I think they got a decent match to them and it worked out well. David, I'm a minute or 2 over time.
That's all right.
It's your fault because you interrupted something.
No, I know.
It's all your fault.
So
in the end, thank you for inviting me. If you have questions or time, I'll gladly stay and answer them. For those of you who want to buy some camera equipment or things, I win fast. If you want to email me and ask questions, feel free. I'll help you in any way I can. Just remember this hangs on my wall at the office. Everyone wants to be successful until they see what it actually takes to get there. And it takes a lot of work, a lot of investment, a lot of self-evaluation. And that's why I sit here at midnight telling myself how much I suck and how I need to get better, because I could get better all the time. That's what we all have to do. So David, thank you. It's an honor.
Man. That was a freaking wealth.
I appreciate it.
That was a wealth of information, man. You got so much going for you.